to bring everybody together, but we have brought you together for a different reason now, right? So welcome everybody. I am excited to be here, and I have a few guests on here. So I'm Kara Lewis. I am the Director of Education for Barrow Children's Neurosciences and the Medical Director for Fetal Neurology. And I added in this talk and added a few guests to do a few cases, and we'll try to make it a little bit interactive if possible. I have no financial disclosures, not going to be discussing anything off-label, and I'm on the National Medical Advisory Board for Make-A-Wish America, which I'd like to put on there, but non-compensated and not relevant to this. So child neurology, I'm going to start with a test poll, and I'm grateful to Christina to be able to help me with some of these things. There should be a poll popping up. These are anonymous. You can put anything you want in here. While you're looking at this, there's just 3 short questions. I will say, while you were looking at this, did you know when Zoom launched these polls? A lot of us have been doing Zoom since about March of 2020. Anyway, these polls, this opportunity to do this, if you see it on here, only started less than a year ago. So it was end of November 2023. So if you haven't heard about it, that's why. But if you see the polls on there, this is fairly newish. Thanks to Christina for helping me figure out how to do this the first time. There's other things that try to make it more interactive, like team chat and whiteboard. Been chatting a little bit on the team. Whiteboard I haven't used quite so much, but this is something that's helpful. Even just thumbs up and thumbs down sometimes can increase the engagement and get people going a little bit on this. So I'm going to do just a couple little cases on here, and then we'll have a few more questions here too. Thank you for those who are adding in here. While you're still adding, I think I can even move on to the next slide. And if you put your questions in, you can't answer, that's okay. So the concept is sort of child neurology is, what is it? Is it a subspecialty of pediatrics? Is it a subspecialty of neurology? Or is it really its own field, kind of a hybrid of the two, but not a subspecialty of either one? So I'm going to end the poll right here.
What was the most unusual one?
I will tell you what the most unusual one.
Sorry.
I might be able to see what the most unusual one that people answered is. Yeah, we got a lot of answers on there. So we got things like neuromuscular, autonomic, neurogenetics, epilepsy, fetal neurology, thank you, immunology, fetal neurology, sleep medicine, headache, neurocritical, autonomic, infectious neurology. That's a good one too. So we will know that there's no, obviously there's no right or wrong answers for any of these things. And I will say, especially for the question about the most interesting, or I didn't ask the most interesting, the most unusual. I didn't ask the most interesting. I didn't ask the most financially rewarding or the most important. But it is just interesting to kind of think about the fact that for child neurology, all of us who are in child neurologists, but there's people on this call who are not child neurologists, the first 2 years of the 5-year child neurology residency is essentially the same as a general pediatrics residency. And after completing the 5-year child neurology, the graduate is eligible to sit for the American Board of Pediatrics certification examination. And then after completing your 5-year neurology residency, the graduate's also eligible to sit for the American Board of Psychiatry and Neurology certification. Now, the majority of 5-year graduates don't go on to practice either general pediatrics or general adult neurology, but they're qualified to do so. So it's just kind of an interesting thing. And the key is really that child neurologists are kind of uniquely trained to handle very complex conditions in a very wide range of ages. So, when we think about sort of how many subspecialty options there are within child neurology, again, we saw a lot of those put in there, including things like autonomic neurology. Put numbers in the chat, kind of thinking about how many there are. But I'll just sort of show you, I kind of was making a little bit of a word cloud, thinking about all the different ones, especially even just at Phoenix Children's, epilepsy and headache and fetal neurology, neuroimmunology. We don't really have neuro-oncology, but we have to bring in guests for that type of thing. Neurodevelopmental, sleep, all these different areas of child neurology. So just the idea is that we get more fellowship programs. Some of these are, subspecialty UCNS certifications, including headache, epilepsy, neurophysiology. And some of these are more niche interests of those who have done 5 years of residency and they have the skills and the brain work to share in these different areas. But that's sort of child neurology. And then when we think about pediatric fields, when I'm working in a children's hospital, which is fun, we don't work in a vacuum. We really work very closely with general pediatricians, as well as other pediatric specialists. This is just sort of a smattering of some of the specialty options we have at Phoenix Children's, and can get people to come in even on weekends. I do get a lot of adult neurology residents who are very impressed when I can get an ophthalmologist to come in and see a patient in the hospital, or I can get a rheumatologist on a weekend to come in and see a patient in the hospital. And that's a very wonderful thing about a hospital like ours. And then within Barrow Neurosciences, and that's a lot of people on this call, we have various subspecialties in addition to neurology, with neurosurgery and neuroradiology and developmental pediatrics and neuropsychology and psychology and physical medicine and neuropathology. So we work together closely. So one of those things we're trying to, the idea of doing more of a multidisciplinary presentation, I thought was kind of fun to do. So the idea of having complex neurological disorders in children came to me after I've been doing a number of weeks of inpatient service and really seeing a number of conditions and cases that really needed group brains, and having to make sure we can get all these things in. So I sort of pulled in a few people for this. So I'm going to pull in my first case here. So this is a patient who came to see me in the outpatient clinic for concern of an abnormal MRI. And child came to see me with the diagnosis of skin lesions associated with neurological concerns and an abnormal MRI, or the skin condition has association with neurological concerns. And so I'm going to, instead of just explaining the things, I'm going to show you some of these pictures here. And this is some pictures available to us through our ARC mobile app. And this is from the dermatology note at 2 weeks of age. And so just describing it without saying what it is, they're describing that extending from the left parietal scalp to the mid-nasal nasal dorsum, there's a 14/12 brown plaque. There's hypertrichosis. And then contained within and sort of over the eyebrow here are 3 pink papules. And then just superior and lateral to the left eye, there's a 4 centimeter discrete nodular component. And then diffusely on the trunk and the extremities, including in the diaper area, which I'm not showing, are innumerable scattered 3 millimeter up to 1 centimeter brown papules and plaques. And so this is sort of what the skin part of it looks, but they're also coming to me with imaging. And so I'm able to look at the imaging of this. And again, this is just a few representative pictures, and the description of it, without again saying anything about it, is these are pre-contrasted T1 weighted images. There's this nodular T1 hyperintensity in the left anterior medial temporal lobe above the temporal horn. And it's measuring by 11 by 6 by 6 on some of these different views of this. And there's no overt enhancement when contrast is given. And there's no associated vasogenic or cytotoxic edema. I didn't show you the T2 weighted images, but the lesion is minimally hypointense on the T2. And there's no additional parenchymal abnormalities identified other than this area here. There is this area up here, which is this left subcutaneous sort of oval-shaped mass in the lateral frontal orbital region above the upper eyelid on the left side. And this one is homogeneous. It's isointense on T2. It's isointense on T1. There's no macroscopic fat in there. There's no diffusion restriction. There's no intralesional hemorrhage or phlovoids. And after they give contrast, there is avid and homogeneous take-up of the contrast. And there's also some thickening of the skin and the superficial subcutaneous tissues of the left forehead and face extending. And in the regions of the involvement, there's the fat is thinner and there's multiple nodular projections. So these are some of these pictures that we're seeing on the imaging here. So case one question. So I'm gonna have Christina put up this question on this one as well. This may be up there. So the idea is, we're seeing skin and we're seeing brain. And I think people are already adding in some answers on here. So I'll give you a few more minutes to add in on this question. But this is something that we think about a lot in terms of the combination of two different fields and where we can get the most information and how we get the information of it. So I'm getting a number of different, I did throw in a couple answers or a couple options in there that were going to probably be none. So there are a couple that nobody's answering, but there's a few that are answering things. But I'll tell you, most people are doing extremely well on this. This is anonymous, so no worries about that. All right. I'll leave the poll up for a minute, but I'm going to move on to sort of the idea of neurocutaneous disorders. The other term of this is phacomatoses, which was coined in the 1920s or 1920. Something with the Greek word for birthmark. Everything has a Greek basis from it. But the idea is it involves structures from the ectoderm, which is central nervous system, and the skin, as well as the mesoderm, which is the vascular system. And there's some that are really, really common. So I know we have some residents on here, and these are the ones you have to know for your boards. Adult neurologists need to know these too. But neurofibromatosis type 1 and 2, very common. Tuberous sclerosis, von Hippel-Lindau, and Sturge-Weber. So these are ones that are, everybody needs to know about. Everybody should be very aware of these. They're sort of classically divided into three different subgroups. There's the melanophacomatoses, which involve the hypo and hyperpigmented skin abnormalities. There's vascular phacomatoses, where the cutaneous lesions are also associated with low flow or high flow vascular abnormalities of the skin and the central nervous system. And then there's sort of the other. So always have to have an other category. And so the two big ones in the melanophacomatoses are hypomelanosis of Ito and incontinentia pigmenti. And then they show MRI changes. The hypomelanosis of Ito shows the white matter abnormalities, there's cystic lesions, there's prominent perivascular spaces. For incontinentia pigmenti, there are brain concerns, including hemorrhagic lesions and ischemic lesions, and then very specific patchy punctate lesions that show restricted diffusion. The vascular phacomatoses are the ones that you think of the most, are ataxia telangiectasia and Rendu-Oster-Weber, which I think was Oster-Weber-Rendu when I was training. Depends on how old you are when you're training. Ataxia telangiectasia involves the diffuse progressive cerebellar atrophy, and there's associated cerebellar ataxia, ocular abnormalities. So they come to the neurologist quite frequently. And then the Rendu-Oster-Weber involves multiple arteriovenous malformations in the brain, but also in the lungs and in the GI tract. And the other two big phacomatoses involve Proteus syndrome and basal nevus syndrome, and these both present as overgrowth syndromes with high risk of tumors. So I'm ending my poll on that one there. So there's a good article about all of these, and I can share these with the residents later if we want to, but won't put that on here. So what is this condition? So this is a condition that we call congenital melanocytic nevi. And it can be abbreviated as CMN. And these are collections of melanocytes in the skin. They can extend to the muscles and the adipose tissue. They're present at birth most of the time. The location can be anywhere on the skin. And the incidence of this of any size is said to vary between 1% and 31%, just in general. And they can be various different areas. They can be flat, they can be palpable, they can be both. In this child, for example, there were ones that close your eyes, you can't feel it if you touch it, but there's other ones that have hair on them or don't. The hypertrichosis or the hair on them can be present at birth or can develop later. They're not identified prenatally, so for the fetal neurologists of us in the group. This is not something that we see on imaging beforehand, but they change over time, and monitoring is essential. And when you get to concerns of needing the neurologist and having child neurology's central nervous system issues and other systemic involvement, this is more in the syndrome of CMN syndrome. So I actually have two experts on here, which is really fun for me. The first expert I have on here is the one who actually sent me this consult. So Dr. Harper Price, I think, is on here, who is the division chief of pediatric dermatology, and is board certified in both adult neurology, child neurology, all this stuff, and has written articles on this and is a national expert, recognized expert, and has done some of these articles in addition with the other nationally recognized expert, Dr. Yasmin Kaku, who's a neuro-oncologist and who's written extensively about this, and we'll have her on here too. But Dr. Price, are you on here today?
I am. Good morning. Thank you.
Good morning. Thank you for joining. This is fun.
Thank you for having us.
Do you want to say anything about this? See what I said right or wrong about this condition?
Oh yeah, no, your summary was great. I think the nomenclature and sort of the way we refer to these things, even some of the things you mentioned, like hypomelanosis of Ito, is more based on cell type and genetic mutation now. So it is a really confusing type, just these neurocutaneous things change a lot, especially with from the dermatology side. So we do see these patients, I think the tide has changed, and Dr. Kaku is also an expert on here. I'm happy to see her, that who we image, and that usually comes from the dermatology side as far as making that decision, but may also come to you as neurologists. And it's changed. So a lot of what we do now is, very large CMN with multiple, we call satellites, those small lesions. But some of our experts overseas have even suggested if you have 2 or more CMN of any size, that those children need, MRIs, screening MRIs early in life. And Dr. Kaku has examples of very scary things where people have very few of these with significant brain findings. One of the reasons why we image is not just to understand and screen for brain lesions, and try to be able to anticipate if we're going to see side effects and seizures later on, hydrocephalus, headaches, those things like that. We see also a lot of small tumors and spinal cord lesions. So I just wanted to make your group aware of that. It's not just very typical things, and ideally doing this before 6 months of age, before myelinization is ideal. But we do really worry about CNS melanoma. It is the sort of the #1 killer in these patients, even more common than skin melanoma. So although those pictures might have looked a little scary to you that Dr. Lewis put up, that's actually a very normal looking CMN. And so we're very concerned, because once there's malignant degeneration in these CNS lesions, or perhaps they already were from time of imaging, we don't really have great treatments. They can prolong some life in months, but as of right now, there's not great treatments. Although most children with NCM do quite well. And then Dr. Lewis and I saw each other in the stairwell, I think, on rounds one day, and we talked about, how often do you repeat imaging, because we do like the neurology team to see these patients and do very thorough neurologic exams throughout, especially the first few years of life. And we generally, as dermatologists, don't repeat an MRI in absence of any concerning signs or symptoms with just parenchymal isolated small lesions in the brain. If symptoms arise, we're very rapid to repeat that. If it's a negative MR, we definitely usually don't repeat again unless there's signs or symptoms, although nationally some people are repeating at puberty, which is interesting. But because we don't really intervene in most of these, and we do see a lot of neurodivergence in these patients too, autism spectrum, lots of things. So although we can't prove that that's part of this, we do feel that there are other neurodevelopmental and behavioral disorders that go along with this, again, that you might pick up on screening these patients in your office. So just wanted to put a plug for those. And then there's a great little paper that was in pediatrics, which I have on the top here. So if you do happen to be the first one seeing one of these patients and you say, I don't know anything about skin, This is available in pediatrics. It's free. It goes over the neurologic part of this as well as the skin part. And so you can get them started with that.
And that was very helpful. That article was helpful. I did find that, and I have it saved for the residents as well. But thank you for being on that article as well.
Yeah. Thank you. Thank you for having me. Hope that's helpful.
It is very helpful. So, I mean, this is just a condition that is not very well known to neurologists, and that's why it's nice to have Dr. Price and Dr. Kaku on here as well. Just this idea that this neurocutaneous melanosis, which Yasmin is an expert on, is a rare disorder presenting with these congenital pigmented nevi, but also involving the CNS involvement, and that's the part that gets very scary. And again, as Dr. Price said, there's not really as much malignancy in the skin. It's really the more concern about the malignancy in the brain. And so the symptoms usually appear within the first couple of years of life and depend on the location and extent of the brain lesion, but the symptoms can include seizures and cranial nerve palsies and myelopathy and radiculopathy and hydrocephalus. And the most severe issue is that leptomeningeal melanosis. So this is from the article that Dr. Price mentioned and talked about how if they have multiple lesions or more than 10 satellite lesions or giant lesions, they're higher risk for the neurological sequelae of this. But then I go into the article, which is from Dr. Kaku as well, and sort of the new insights into the neurocutaneous melanosis and the things that I learned for that. So I did bring on Dr. Kaku as well, and I'm so honored that she's here, in addition to just having arrived back from Rome. But I also do get to now call her Madam President, as she's taking over the president of the Child Neurology Society at the annual meeting coming up in San Diego. So thanks for jumping on here. I'm glad the time change works in your favor, at least. So
do you want me to say something?
well, the question
Okay.
I would say, I sort of was looking at the article that I have for you and sort of the important points that I learned, really, that if the lesion is giant, there can be a risk of the neurocutaneous melanosis between 23 and 30%. And the prognosis, if they do have the neurological symptoms early, is very poor. My baby that I saw was great, doing great, no neurological symptoms. Spinal involvement is not as common, but can be 20%. And then if they're symptomatic, they often die. So I guess some of my questions might be sort of, when do we keep repeating? And I think I've learned some of this that we didn't need to. So do you have anything to add on this one? I think Dr. Bodenstein had a question for you too, which we can do now or later.
Let me see. I'm not seeing your question, John.
I just had my hand up.
Oh, you had your hand up. Go ahead. Yeah.
When I was practicing in about 30, 40 years ago, the textbooks in neurology said that these were pre-malignant lesions and recommended that the entire lesion be excised and grafted. And I've seen children where that was attempted. I don't think that's done anymore. I hope it's not done anymore. But what is the risk of cutaneous malignancies?
So I think if you talk with the plastic surgeons, they'll say, Harper, you can correct me if I'm wrong, but they'll say that they never see cutaneous melanoma in patients who've had the full lesion resected, the bathing trunk or the largest nevus. I don't think we have a control group for that. So I think that doesn't help us, so I think it's a very personal choice. I also think that the dermatologists are wonderful at just figuring out which the lesions need to be biopsied, et cetera, because there are some that do become malignant, but I guess Harper, you can speak to that question better.
Yeah, John, so the cutaneous management of these has become much more conservative. Dr. Kaku's right, like these are not considered pre-malignant. They're sort of like any other small congenital nevus, although we do feel that the risk of melanoma is probably more like around 5% over the lifetime risk. Think about that in relationship to anyone born in this country has got about a 1 to 2% risk of melanoma just acquired. So it's more than general population, but it's not some of the older literature that quoted 20 to 30% risk. We find cutaneous melanoma quite quite rare, but it's again a rare thing. It still happens. We lost a patient at Phoenix Children's not too long ago, but it is certainly less common than CNS melanoma. So she's right. The decision to remove it should not be due to trying to reduce a cutaneous melanoma risk, because you're probably more likely to get melanoma somewhere else. And it does not decrease your risk of CNS melanoma. But she's right. The surgeons feel very differently, although there is definitely a paradigm shift that's happened in some of the other big groups in the literature about really not removing these. Of course, if they're symptomatic, if it looks like it's turning into melanoma, will be removed. Point being, the most giant of these, resection is impossible. So it's a false sense of, that we're doing something. We just don't have good studies to prove that it really affects outcomes, but we are starting a large registry for these patients. Yasmin has one too. So the hope is that we'll follow them longitudinally, but you're right, the literature is very poorly written and refers to very old ways of managing these. I would definitely recommend sending these patients to a center like we have in dermatology here at Phoenix Children's for management to get the right information.
I think that's the most important thing, is make sure we're staying up on it and doing the more current advice and prognosis and information for the families.
So I'm gonna jump in because there's 3 points I made while I was listening. I'm sorry I didn't get the slide to you, Kara.
That's
MRI
okay.
doesn't pick up every lesion. We have a first paper we wrote was on that. And neurocutaneous melanocytosis, what I like to call it cytosis, it's interchangeable with melanosis, I gather, is not in and of itself the problem. It's the underlying architecture of the brain with respect to seizures and the other neurodivergent things that Harper mentioned. So parents get really, and caregivers get, and we do too, we get a little, anxious about lesions we see. But to date, I have not really understood which patients who have lesions visible on MRI are the ones who go on to have the poorest outcome, except the ones who have the thick, bulky leptomeningeal disease. And those are not always cancer. They can sometimes be what we call malignant hydrocephalus, malignant. Basically, you can't shunt these kids. It becomes problematic. But, the thing is, in 2024, we know that genetic and molecular changes within lesions is what's going to drive things to become malignant. And again, we don't know all the drivers, but I do know 3 things that I would say that are higher risk. One is a patient who needs a VP shunt or any other CSF diversion. It may be that the shunt is a marker of worse outcome and heavier burden of disease, but we've seen kids with very little disease who needed a shunt who developed intraperitoneal melanoma. So anyone who needs to have CSF diversion, if possible, and endoscopic third ventriculostomy is preferable. Number 2, anyone who gets immunosuppressed. So we know that cancer is constantly being scavenged for by our immune systems. So we have a patient who developed inflammatory bowel disease completely unrelated to this condition at age 17 and was immunosuppressed for his IBD, and in that setting developed brain melanoma. Again, it's an N of 1, but there's a black box warning on Remicade now for this. So those would be 2 really important things I'd say we should be very mindful of. And then thirdly, I have a good good news situation. We have a new agent that's in a phase 1, so it's only looking at safety in patients who have certain genetic alterations that are affecting the brain, like other brain tumors, as well as NCM alone. And it's new, it's just out. It works on the MEK pathway. And right now it's open to children ages 3 and up. You don't have to have malignancy. You have to be able to swallow pills. There's a few other criteria you need to meet. But my practice has always been, as both Kara and Harper said, we don't rescan unless there's symptoms. I'm starting to rescan kids over the age of 3 more frequently because we have a possible therapy for them. And B, I don't know, I guess that's it, just because we have a treatment. We never had that before. So you do a test, you want to know how you're gonna react to the test. Now we may have something. Again, phase 1, it's not a home run yet. We don't know, but this is the first time in my 20+ years of practicing with these patients that I've ever had any new agent that's been hopeful.
That's a huge start. I mean, at least it's a start, like having something to have. It's the good news, so.
Yeah.
We appreciate it. Thank you both for joining. I am gonna move on to another case and you all can stay or leave, feel free. But I have I have 2 other shorter cases. This is kind of our big one there. So the second patient, which is also very interesting. This is a patient who I did see the family as a fetal neurology consultation. And so this is a family that came, had an ultrasound done at 19 weeks gestation, which showed an abnormality in the posterior fossa they read as a cyst. And then they did a fetal MRI at 22 weeks gestation that showed concern for a dural venous sinus thrombosis rather than a cyst. And they consulted with me at that time to discuss this a little further. And so these are just some pictures of the fetal MRI. And this is, if you haven't seen a lot of fetal MRIs, this is sort of big picture of the fetus, showing pretty much the entire fetus here within the uterus. And then this is, they can kind of come down to just looking at the brain. This is an axial view of the brain, and we're seeing this abnormality here in the back. And it was read as showing a midline dural venous sinus thrombosis in the torcular herophili, and extended to the right transverse and posterior sagittal sinuses. And they noted on there that in this fetal MRI, no blood flow could be detected in the dural venous sinus malformation at the right transverse sinus, and there was normal venous flow on the left side. So they did think this was thrombosed at that time based on what they could see there. And there were on here focally dilated superficial vessels with the idea that they could be dilated cortical veins along, sorry, missed that one, along the right, the fissure there, but also could be potentially arteriovenous fistula. So these pictures are on there. I get to see the family, and I do these by telehealth, meet with the mother of the baby, the father of the baby, the fetal nurse care coordinator, and we review the imaging and we discuss sort of what we know about dural sinus thrombosis and what I know about this, and having to call in some experts. Dr. Luis Gonzalez is the fetal radiologist, and he reviews this also with the family when he does this, and he gave me some good articles. So I was kind of able to have some information even before I met them, noting that some of these, quite a few of these dural sinus malformations, when you diagnose them early, are thrombosed to presentation, like we thought this was here. And that a lot of times the size is not predictive, but the natural history is often that they can spontaneously regress without sequelae. So that's something that's helpful to be able to tell the family. And then if there's not associated venous hypertension or ischemia, then the outcome is excellent. Nice to be able to tell families that. But obviously, if it's associated with venous hypertension, then you can get thrombosis, you can get hemorrhagic infarction, you get brain destruction. And so the lit review on that article that I had before when I was meeting this family kind of talked about congestive heart failure in 25%, ventricular megaly in 27%, hemorrhage in 10%, parenchymal injury in 22%. And the poor prognostic factors are ventricular megaly, parenchymal injury, and arterialization. And then the good prognostic factors are more the decreasing size and the presence of the clot. And it was noted that it was not associated with coagulopathy in the mother of the fetuses, so generally don't need to do a coagulopathy workup. And if there is flow present, you have to really watch for that high output cardiac decompensation in the kids who survive. Sometimes, 66% have normal development, which is great, but 20% have developmental issues. 30% of those are severe. So, my recommendation is we're going to do another MRI. This was pretty early on. This was 22 weeks, and they wanted to get more information. So looking and seeing what the evolution was, and then talking about seeing the specialist in this, which is our neuroendovascular specialist, Dr. Abruzzo, who I have on here as well. So they did do their second fetal MRI at 22 weeks. And this is just, some pictures of this one, which still showed the dural venous sinus malformation, and still showed some of these areas there. It was read as qualitatively smaller, significantly less pronounced compared to the one at 22 weeks. And there was no ventriculomegaly, which was good, no hemorrhage, which was good, no diffusion restrictions. So there's a case question up there. So now that you know that I think it's still up there, now that there are CNS vascular anomalies, what do you do? So, you counsel him. I'm meeting this family prenatally, and then I also met the baby later. One of the best parts for me about doing fetal consults is I get an opportunity, sort of a ready supply of newborns, these 4 to 6 week babies, which is very fun. So I see this baby at 6 weeks. He'd been born at 39 weeks, low blood pressure, heart rates, did well after delivery, discharged at 3 days of age, did get the rapid MRI at 2 days of age, which confirmed the venous anomaly, and it confirmed no ventriculomegaly. So this is the question that's up right now. I'll leave it up there just for another minute. We've got about half people participating. So this is just the MRI at 2 days of age from another hospital, but we can get those pictures. And it confirmed the venous anomaly. Again, no ventriculomegaly. But I did review it with my colleagues, including Dr. Abruzzo, saying that it's reassuring, but it's a little bit ambiguous. Hard to know for sure what this means there. So I'll just say from an outpatient standpoint, what do I do? Baby looked good, no neurological concerns, didn't have seizures, was eating well, social smile, normal head size, which is important. Fontanelle was open and soft, no focality of the extremities, but there were some skin lesions. So, on our same skin thing with cafe au lait spots and some nevi on the glabella and the upper lip. And so in advance of my visit, I did call in my colleagues, Dr. Gonzalez and Dr. Abruzzo. So even though Dr. Abruzzo had not met this child yet, I was able to give them some information, sort of that if they don't have the cardiopulmonary symptoms, all these things, the seizures, the macrocephaly, the hydrocephalus, we don't have to do anything urgently. So that was important for the family. Like, what do we do right this minute? Baby looked good, but that imaging was kind of relatively ambiguous. And so the recommendation is to get more imaging. And so what other things would we do for this child? I will kind of jump past these pictures again, we did pictures at 2 months of age, and I saw the child again after the 2 months. And we did pictures again at 7, 8 months of age as well. And I can pull these back up in a minute, but the idea is sort of what other specialists would be helpful. I did send this child to NICU clinic to get multidisciplinary neonatology, physical therapy, occupational therapy, speech therapy, was doing great. The child did go to hematology oncology, even though, remember, my thought is that they're not associated with coagulopathy. They did go, everything was fine, get a little nervous, all the thrombophilia workup was negative, and did actually send this child to dermatology too at the request of our expert due to the skin changes. And then we see our nerve interventional. So these are the skin changes just before I get to this. They did have some bilateral asymmetrically distributed brown macules and patches along the midline upper back, the left posterior calf, the thigh, a couple other areas, at least 5 of them, no axillary inguinal freckling, and did have this violaceous patch in the upper cutaneous mucosal lip here, and then an area in the glabella on there. And there also was possibly a leg length discrepancy that they noticed as well, but did not at this point meet criteria for a specific vascular syndrome. But getting dermatology made us say we need to get ophthalmology and maybe orthopedics because of the potential leg length discrepancy. So I did ask Dr. Abruzzo to come join on here. So Dr. Abruzzo is one of our attendings here on faculty and is completed residency in diagnostic radiology, but is also board certified in neuroendovascular surgery. And so I know you met with this child at 8-month imaging, but you were counseling me even prenatally and the 2-month imaging. And he was also the one who told Dr. Price, referred to Dr. Price because the concern of the vascular and neurocutaneous. So I did bring you on it, which is nice. You don't have to necessarily say anything, but I would say, having you involved, how do you counsel these families about the neurological risks, and how do you help a family decide, especially sort of, do you do the invasive procedure, more definitive studies if the child is doing well to find things out, knowing that if you wait until they're not doing well, that's a bad option.
Hi, Kara. Thanks for inviting me today. Can you guys hear me okay? I'm using
Yes.
a headset. Not sure the microphone's working.
Yeah, it sounds
So,
good.
so dural sinus malformations, that was a nice overview of that. We see maybe one every couple of years. In the last 30 years, I've seen probably, I feel like 10 of them. The majority have benign outcomes, the ones that are diagnosed prenatally, although some have very aggressive and not so benign clinical courses. And the the worst sort of neonatal course that we do see in this population is going to be high output congestive cardiac failure with pulmonary hypertension. That is a marker of a very malignant clinical course. And those patients have a very high mortality and very substantial morbidity. And thankfully, that is a minority of these patients. Probably the smallest subset that we see are the ones that present in the neonatal period, and even in the congenital, even in utero. The worst cases I have seen with in utero signs of early heart failure, and those patients tend to do poorly. The other manifestation of this disease is hydrovenous dysfunction. So that means that the venous pressures, CNS venous pressures are elevated, and that results in arachnoid granulation dysfunction and communicating hydrocephalus, and also cerebral perfusion abnormalities that are related to the cerebral venous hypertension. And there's a spectrum of that, which ranges from mild to severe. And it's worth sort of pausing to take a minute to understand what sort of the pathogenesis of this lesion involves, and why there's such a diverse range of phenotypes that we see in this patient population. The primary lesion, that at least this is what we think from seeing so many of these cases now, not personally, but sort of collectively as specialists in this field, we think that the primary lesion is the overgrowth of the venous sinus, is this massive dysplastic overgrowth of the venous sinus. And that because of the hemodynamic derangement caused by this very patulous, slow flow venous structure with recirculation, vortex formation, intravascular thrombus resulting from the sluggish recirculation of blood and stasis, there you can develop mural thrombus within this massively dilated dural venous sinus, and that is a soup of endothelial growth factors, right? So PDGF is released in very large amounts in this mural thrombus. Vascular endothelial growth factor is released in very large amounts, and because of the window of development, the circulation is very susceptible to these signals. And if there is a propensity to form arteriovenous shunts, which there can be, we don't understand what differentiates patients in terms of genetic markers, but we suspect that there are certain genetic factors which play a role in tipping the scales towards arteriovenous shunt formation. But basically, you have this environment which is very rich in angiogenic growth factors, and because of the mural thrombus formation, and you have a very immature fetal circulation. And in vulnerable patients, this stimulates the formation of arteriovenous shunts to the massively enlarged dural venous sinus. And again, this is a spectrum. So it can be just a couple of small shunts or a large number of massive arteriovenous shunts. And on one end of that spectrum, you have heart failure because of the massive shunting that sort of makes a vein of Galen malformation look like a kitten, really. If you sort of can just imagine, and this is the tiger, right? So in the worst case scenario, there is massive arteriovenous shunting. And then on the other end of that spectrum, you can have very mild arteriovenous shunting. And then as on the far end of the spectrum with massive shunting, heart failure and pulmonary hypertension are sort of the worst problems. But on the other end of that spectrum, it's venous hypertension, hydrocephalus, and there's a middle ground in between where you have sort of a mixture of mild heart failure and different severities of hydrovenous dysfunction. The worst forms of hydrovenous dysfunction are going to involve very rapid encephaloclastic brain injury, right? So the melting brain syndrome, similar to what we see in the vein of Galen malformations when they're at their worst. So it's a mixture of perfusion steal through the shunt, and it's a mixture of cerebral venous hypertension, which thwarts normal brain perfusion. And so these are all the different things that we can see. And we sort of look at how the patient is symptomatic at any given point in time. And because this is such a rare disease, it's not, we can't be, we can't predict with a lot of accuracy exactly whether or not a baby, when it's born, when we make the prenatal diagnosis, is going to have any of these problems. But some of the indicators of a benign clinical course that we see in utero are thrombosis. But I do want to sort of caution against the assumption that thrombosis is a guaranteed benign clinical course, because it's not.
Right.
Some of these babies will develop very aggressive dural venous sinus thrombosis that actually has a bad outcome, simply very much like we would see in a run-of-the-mill venous sinus thrombosis. Sort of just think of venous sinus thrombosis, perinatal venous sinus thrombosis on steroids, right? So that you can see that. But remarkably, I can tell you from my experience, my personal experience, and what's reported in the literature, when you see thrombosis in these babies, they tend to do better, right? So there's this spontaneous involution of the dural sinus malformation and this adaptive remodeling. And the adaptive remodeling process, remember that the whole circulation is to figure out how it's going to get the blood out of the head back to the heart. So that adaptive remodeling process often looks very bizarre, right? So there's all kinds of anatomical variants. Some venous structures look very hypertrophied, the ones that normally are very small and we don't even see. And so those hypertrophy venous structures can be misleading. They can look like an AV shunt, but they're not, right? They're not AV shunts, they're benign. And some of the tools that we have now in postnatal imaging, we can't really do this in utero, but on postnatal imaging, we have very sensitive, flow sensitive MRI sequences, right? Arterial spin labeling, time of flight, MRA sequences that tell us that these are slow flow structures. They're not shunting structures, and they're likely to just be normal anatomic variations that develop in response. They're adaptive changes that have occurred in the circulation to adapt to this loss of normal torcular function, right? So the torcula may be non-functional, and in order to adapt to that, there's a shift towards the anterior venous confluence, which is the cavernous sinus. And all of that adaptation involves hypertrophy of venous structures that normally would not be very prominent. And so it can be very scary, and there's a lot of uncertainty looking at that. Is there an AV shunt lesion?
Yeah, so that's the biggest thing, is trying to figure out how much we can tell families to be optimistic versus worried. I think that having you available to us as an expert to sort of know which imaging to order, that was important for me. So reaching out to you, be able to tell me which types of imaging were ordered rather than the limited rapid study, and then make sure they can come back to you. And so it's been nice to be able to see them, have you see them. They've come back to me. They're going to come back and see you again. You know, they do have another visit with you with the idea of potentially doing even further imaging.
Yeah.
And also at your request, they did see dermatology, and they're going to have another visit with the genodermatology clinic coming up at 15 months of age. And they're going to follow up with me too. And then on the question that I asked people, which is nice, there's sort of a 50-50 split about whether you would, you know, only, you know, see them again if the seizures develop or there's rapid head growth, or if you would consult neurovascular now. And so I think that that's been nice to kind of be able to get some information about that. So I appreciate your help on there. I'm going to move on really fast to the very last case, which is much shorter, but kind of fun. But I appreciate your having here very much, Dr. Bruzzo. So the last one is just interesting because there's a good little video to show everybody, and I did have to involve a number of people on this child. So this one is a previously healthy child that we've seen on service just recently, had 4 weeks of stiff legs. And so the history is just somewhat of the interesting part of it. They went to the ED 12 days after onset and said, child's fussy and there's a question tenderness to the ankles and the knees, but the examination was pretty reassuring, so they didn't do much at that time. Child came back to the ED 26 days after onset, and again, this child is not walking well. They noted continued limp and leg pain, no fever, and at this visit they did x-rays of the knees and the hips, which are fine. They did some labs, they did a hip ultrasound, and they discharged the patient and said she'll probably go see orthopedics in the outpatient clinic. Did see orthopedics. This is now a month after symptoms, walking with a limp, progressive pain, sometimes refusing to bear weight, and said was crawling and had been a good walker before all this. And they were treating kind of regularly around the clock with ibuprofen or Tylenol. The orthopedic consult did not think it was orthopedic in nature. They placed referrals for neurology, rheumatology, and for an MRI brain of the spine. So this is interesting because this is a lot of people getting involved and trying to decide what was going on. The MRI of the brain and spine were done on the outpatient. It was read as showing a concern for a syrinx. So then the orthopedic team that had ordered the study then also placed a consult for neurosurgery. So now a lot of people are getting involved, as well as genetics, because there was some gross motor delay and there was a family history of a neuromuscular concern in a paternal great aunt. And then the last ER visit was 5 weeks after onset. And at this visit, they said ongoing bilateral pain, abnormal gait, and headache. So that gets them admitted. But they also had concern about possible loss of milestones and change in words, decrease in number of words, and also just not, really not acting right. So at this point, neurology got involved on an inpatient basis rather than waiting for outpatient. And the family did say child had 14, 15 words before this, was now just using 3 or 4. And so just for fun use, I actually have a couple of videos, again, available on our website. So this is a video that the family shows through, that the family provided this baby at home trying to get up, using the head somewhat to get up, having to push off on the legs, very complicated way of getting up off them, and then standing and walking a little bit. And then this video was obtained during the neurology consultation inpatient. Audio, because there's not saying anything other than cute baby. So cute baby, a little irritable, not talking much, but definitely visually alert, interactive with us, and does walk, but has this very odd stiff-legged gait, legs very, very straight, legs feet kind of out, wants to be held and kind of cranky. So we have pieces of information at this point. We had this MRI of the brain and spine. The brain was completely normal. Then there was some CPK numbers that were obtained, and these were mildly high. And then we have sedimentation rates. Normal is less than 10. We got numbers that are 31 and 27. We have LDH that was a little bit high. We ended up doing a spinal fluid, which was a traumatic tap with quite a few red cells, but normal protein. Reflexes were kind of hard to get, but present, but hard to get because of the stiffness of the leg. So the question on this one is really, who do you want for this child? What is this? Is this neurologic? Is it orthopedic? Is it neurosurgical? Is it rheumatologic? Infectious? Movement? You guys are answering the question. We have a few people adding in here. I'm seeing a lot of answers for rheumatology and neuromuscular neurology specialists. So orthopedics, we already did see them. They already said it was probably not them. Rheumatology came in the hospital. So very exciting. They did an inpatient consultation. So for those of you, 57% of you who said you wanted rheumatology, they said it was not them. They were not very excited about it. Neurosurgery did see the child as an outpatient to look at that little small area. And they really said that's probably a enlarged central canal, but reasonable to repeat in a year, follow up in a year, but not like the cause of all these things. So I'm seeing the majority asking for a neuromuscular neurology specialist. And then a few people also asking for movement. So that's kind of what we did. I will tell you, we consulted the fabulous Dr. Chow Haas, who is one of our subspecialists in neuromuscular medicine here, did a residency here, did her fellowship with Barrow Neurological at St. Joseph's Hospital. And I was communicating with her during the hospitalization, and we were able to get a visit with her afterwards. So we don't have an answer yet, and we don't have a whole lot of time, Dr. Chow, but thank you for joining in. I will say I appreciated your helping me with this, and this is kind of what I like to do.
Hi, can you hear me?
Yes, I can hear you.
Okay. I don't know if I have much to add because I still don't know what it is. I'm seeing her back in a couple weeks because the first time I saw her was the day after she was discharged from her hospitalization. And I think the biggest thing that I saw on my exam was that she was just so tender to palpation in her legs and was like, would refuse to bend her knees basically. But other than that, like was totally appropriate and normal. So I'm not sure. And like with the MRI, it's like she does not have a myositis. She had normal CK. So to me, like I know a lot of people had brought up myositis was a concern, but that really, like her workup was pretty much negative for that. So I don't know. And I had reached out like to rheumatology again because she had those like bilateral small knee effusions, and they were like, nope, it's still not us. So I'm just gonna see her back and see what she looks like and probably repeat labs and things at that point.
Yeah, no, it is a fascinating one. And so I'll leave this one as unknown, although based on your recommendations, she had the effusions in the knees, but she also had some popliteal lymph nodes. So you talked about maybe that'd be something that could get into later. The family actually then did go to hematology oncology just to be assessed. And they were very clear that there's not evidence of leukemia lymphoma here. They said in their note that they were going to check with rheumatology and neurology with Dr. Chow and talk about maybe an empiric trial of steroids. They had thought it was myositis, but they repeated a urine myoglobin, which is negative. And again, as Dr. Chow said, the muscle, we did an MRI of the muscle that was negative for myositis. So just for sort of interest sake on that kiddo, do we have a final answer? No, we don't, which is good on our last case. And are there going to be more studies and more specialists? Yes. And so they do have some pending visits coming up. They have a genetics outpatient consult just given dad's aunt, had a dystonia, a progressive dystonia, was in a wheelchair. Details not known. There is going to be a follow-up neuromuscular neurology visit with Dr. Chow. And then because of this concern with oncology and rheumatology, I did actually reach out to the family just to kind of hear, and got started on steroids. So is now a couple days into steroids, and they think maybe she's better. So hard to know. Interestingly, she had gotten dexamethasone when she had her MRI scan. And that was the first day she'd been the best. So the family had been kind of wondering whether that would be helpful. We're not sure what we're treating is the problem. I did clarify, she's still not talking much, which is strange. She's understanding everything. So she may just not be talking because she's in pain. And they also did get her to meet a speech pathologist as well. So anyway, that is the end of that case. That may be something to come on later. I will just say as our sort of our last thing.
You didn't mention the plantar response, and you didn't mention the reflexes.
Yeah.
Is the pain in the legs from muscle tenderness or from something else?
That's a good question, John. The pain was not from muscle tenderness. You could palpate the muscles and there was no pain. There seemed to be pain when you moved at the knees. And because this child kept her knees really, really straight, like it almost looked like a gower on that video, but it's not from proximal weakness. It was really from not wanting to move her knees. So reflexes were hard to get at the knees. I was able to even hold her and she was relaxed and her knees were out. So her knees, I think reflexes were present, but we checked protein just in case. And the toes were very mute. She mostly just pulled away. So she's complicated. We are at the top of the hour. I appreciate everybody's excitement and enthusiasm about all this stuff. Mostly, oops, sorry. Thank you for having the invited guests coming on. You're a terrific audience. I will release you back to your regularly scheduled Monday. Thank you all for being here.